So she does not, and I hope that I do not, have any genetic predisposition to risk factors such as hypercholesterolemia. So risk factors, we know, are not the same as disease. There may be other issues with regard to genetic predisposition. The first true gene for myocardial infarction was reported last year, the MAF2A transcription factor gene. It is not a risk factor. If you have that gene, you will have a myocardial infarction. The penetrance is essentially 100%, so that's fascinating. But if you have risk factors and you have a genetic predisposition, then you injure your endothelium. Minimally, you decrement your availability of nitric oxide. You certainly produce a pro-inflammatory state, and you also increase markers of thrombogenicity. Example, perhaps, of inflammation might be CRP. And we've been hearing that if you then proceed through what the vascular biology destination of endothelial dysfunction is, then you develop atherosclerosis, and one of the markers might be coronary artery calcification. I think it is short-sighted to look at any one of these four quadrants and say that's how we're going to evaluate the vulnerable patient, because I think they're all helpful. Even if you knew that a patient was headed in this direction, you might have to go back over here or someplace else to find out what the appropriate therapy would be. And so I think when the dust settles in this field, we will still have risk factors, genes, vascular biology, and imaging diagnostic techniques. Now, the one that I want to concentrate on for the next 15 minutes is endothelial function. And as all of you know, the concept of endothelial function is a misnomer because there are many endothelial functions. The endothelium, if healthy, makes many molecules. Nitric oxide, TPA are examples, which are vasodilatory, thrombolytic, disaggregant for platelets, anti-smooth muscle cell proliferative, and lipolytic. But if activated, the endothelium makes a whole other host of molecules, which are vasoconstrictive, thrombotic, adhesive for platelets and white cells, producing smooth muscle cell growth, and certainly hallmark of inflammation. Now, you can't just look at one of these if for no other reason that a specific intervention may change these in opposite directions. What am I talking about? Estrogen. Estrogen, as we'll learn, at least temporarily improves nitric oxide availability, but at the same time increases inflammation. And so you couldn't even predict from that what the result of giving a woman estrogen would be because of the complexity of endothelial function. Having said that, there are some general relationships which hold. If you look at CRP and you look at endothelium-mediated vasodilation, in general, these have an inverse relationship. Individuals with low CRP have robust responses to acetylcholine, whereas those with high CRP have poor responses to acetylcholine. And it is reasonable to think of nitric oxide as one of the major mediators of endothelial-dependent vasodilation as being connected with progression of atherosclerosis. In experimental animals, if you inhibit nitric oxide synthase with a specific synthase inhibitor, atherosclerosis increases. If you make more nitric oxide available by giving the precursor, atherosclerosis decreases. And so availability of nitric oxide, one of the endothelial functions, might be interpreted as a way of measuring the rate of progression of atherosclerosis. Well, what techniques do we have? Well, I'd like to stand up here and tell you we have many clinically applicable techniques for measuring endothelial function that are helpful. My first large message tonight is we don't. The techniques that we have for measuring endothelial function, at least flow-mediated dilation, are a totality of vascular biology that is going on at any one time. Now, this concept that won the Nobel Prize for Medicine in 1998, first put forth by Furchtgott and picked up by others, is applicable for coronary arteries. You can look at endothelium-mediated agonists, such as acetylcholine, infuse them down coronary arteries, and you may get, just as you do in rabbit aortic preparations, vasoconstrictive responses or vasodilatory responses, and those mean something for cardiovascular events. If you have a vasoconstrictive response to acetylcholine, your subsequent over 7-year frequency of cardiovascular events is dramatically increased, but it's not only with regard to acetylcholine. If you look at it with regard to cold pressure, or you look at it with regard to flow-mediated dilation, although you're always looking at something a little bit different, you still get substantial discrimination in cardiovascular risk rates. Those are patients with coronary artery disease. Here are patients without coronary disease, and yet the vascular biology predicts exactly the same thing, whether you're looking at resistance changes or diameter changes to acetylcholine, still a 3, 4, 5 time prediction of increased risk. Moreover, in getting back to the central concept of a vulnerable patient, if you look at coronary blood flow responses to acetylcholine, you actually can predict the risk of stroke and TIA. There's nothing different going on in the head than in the heart, and that's a very, very nice concept where we see crosstalk between the different vasculatures. Now, let's now turn to plethysmography and quickly show you exactly the same data. Those individuals who have the most robust flow responses have over approximately 3 years the smallest number of events. Same thing true with acetylcholine-induced forearm blood flow responses, predicting an adverse prognosis, and data showing that in fact that this is free radical mediated. Those with with the smallest responses to antioxidants have in fact the smallest number of events. Probably the technique which is most widely used is that of brachial artery flow-mediated dilation. Here's actually an image of my flow-mediated dilation. It's in essence a brachial artery endothelial stress test. My left brachial artery at rest, 1 minute after 5 minutes of occlusion, and the resultant vasodilation. And the reason for being happy over having more than 10% flow-mediated dilation is that it gives me about 1/3 the risk of having a cardiovascular event over the next 5 years in small and in larger studies. And now, using non-invasive techniques, we can begin to screen larger and larger groups, both for coronary heart disease as well as cardiovascular events. Is this technique going to be widely used to predict cardiovascular risk? I don't think so. To get the kind of pictures that I just showed you of the brachial artery, we've had to lock our technician in a room for the past 8 years. He does nothing else but flow-mediated dilation, and that's not broadly applicable. And yet, I'm still optimistic about this technique. Let me show you why. If you have good endothelial function as measured by brachial artery flow-mediated dilation, we can predict your operative technique. Again, not particularly different, but here's something very, very interesting. And that is, let's take us back to 1997. And that is prior to the report of the HRT studies. In 1997, most physicians were advising HRT for postmenopausal women to reduce the incidence of cardiovascular risk. And yet in 1997, we wrote that these studies were futile because they would not show any beneficial effect. Now, why is that? Because of data such as this, which reported that the short-term benefit on nitric oxide availability that is present within 15 minutes of giving intravenous estradiol were absent if you looked out at 6 months, a finding which is held up. And so there's no long-term improvement in the vascular biology on HRT in postmenopausal women. And by the way, as mentioned, indices of inflammation such as CRP are impaired, indices of thrombosis are increased, and many things that people forgot. You get more small dense LDL, and so the entire prediction of what good would be done was based upon things like changes in LDL and HDL, and that's monosomatic thinking that was very, very dangerous to a lot of women. Looking at the entire spectrum of vascular biology, it was very easy to predict years ago that HRT would not be beneficial. Now, here is a more challenging study published a couple of years ago. This is a study of 350 postmenopausal hypertensive women who were treated with an array of antihypertensives. The group started at the same blood pressure, a hypertensive level. They were all successfully treated, and they were then categorized into those who had less than or more than 10% improvement in flow-mediated dilation, despite the fact that these two groups of women had identical blood pressures on treatment. So it's not just blood pressure, because those women who had a better improvement in vascular biology had less cardiovascular events, both of a cardiac and a cerebral nature, in subsequent follow-up. At the American Heart Association meetings and reported this week in JAMA, we found in a head-to-head trial of two statins in patients with coronary disease that, in fact, we had greater improvement in flow-mediated dilation in patients with more aggressive lipid lowering. That translated to a greater reduction in CRP. That translated to an absence of progression of disease with lower LDL therapy as compared to less LDL lowering. Now, on Monday at this meeting, the group is going to report the mortality and cardiovascular rates in a very similar trial using exactly the same regimen in a trial called Prove It. We would predict from these that what they're going to find is what the vascular biology found, what the IVUS found, and that is more LDL lowering was better. If we're correct, that substantiates the concept of using these for intermediate biomarkers to help us shorten studies and reduce the cost for a prediction, because what we've learned over the past 10 years is, although these tests may not be terribly applicable for an entire population to screen risk, they're terribly good in predicting what happens with therapy. Well, the conclusion at this point is that both coronary and brachial artery endothelium-dependent dilation are quite predictive of cardiovascular events, whether they ever see the light of day as a clinical technique or not, and probably most importantly, that we can use these in less expensive and shorter studies to predict the real therapeutic responses of an agent or in specific patients. That remains to be shown, but I think that those data will hold up. Thank you very much.